If we look at the history of spine, OLIF is really relatively small in the history of spine as far as surgical approaches. We have T-LIF, we have P-LIF, we have laterals, we have A-LIF, and OLIF is the one and last surgical approach to the spine. There won't be any other surgical approach to the spine because there simply is not a corridor for them to be in.
The oblique lateral interbody fusion, the OLIF, is you're sort of splitting the difference between the A-LIF and the L-LIF.
Direct lateral surgery, while it beautifully removes potential complication from all the anterior spine elements, viscera, it's conducted through the psoas muscle. So that trans-psoas approach brings into play the potential for neurologic complications.
The oblique lateral interbody fusion is a minimally invasive way for us as surgeons using newer technologies to implant cages into patients and actually basically restore their sagittal balance and correct their spinal deformity using minimally invasive techniques.
There's too many times when the term MIS is thrown around as a marketing tool. Yeah. But the reality is, it's a way to manage tissue better than we've managed it in the past.
It's not the size of the incision, it's what's going on underneath the skin.
We can many times do this as a single position. In other words, the patient can remain in one position to do the surgery, whereas previously this was like a two-stage procedure. So we would do the anterior part and then flip the patient and then do some sort of posterior instrumentation. By having the patient in a lateral position, it allows the abdominal contents to sort of fall out of the way, so it makes the exposure easier. We're more posterior or lateral to the vascular structures, so we don't have to mobilize them as aggressively as you would with a traditional ALIF approach.
With tubular retractors and long-handled instruments and light sources and image guidance, we can work through these retractors outside of the person's body through smaller incisions that are strategically placed.
One of the things that Camber has done, it's beautiful in its simplicity, is they've taken a 50-year-old retractor called a Hohmann retractor that was used to put around long bones, right? Put it around a fibula when fixing a fibula fracture. And they've put that Hohmann tip on the end of a blade that just has a slight radius of curvature, enough to stop it from advancing too far on the spine, and allows us to safely dock that retractor blade at each disc space above L5 in a way that really takes the great vessels out of play.
It's simple, but it's also elegant because it solves the problem in a way that you don't have to reinvent the wheel. And so it was easy to then adapt it to our problem, which we needed to solve. So we came to the engineers and got our solution.
You're able to put in a cage really kind of like an ALIF cage in a minimally invasive approach through basically a 2 to 3 inch incision on the side.
And it's not just the skin incision, it's what you're doing underneath it. So you're bluntly dissecting through the muscle rather than cutting it. So that saves the muscle for post-operatively when you need those muscles to function for the post-op period.
I think the OLIF is the quintessential minimally invasive spine technique. It disrupts the least amount of tissues. You don't have to go through the psoas muscle, and you generally aren't working between the blood vessels, which are two major potential complicating factors with other approaches.
Now that we've sort of really perfected a lot of the ways to get where we want to be less invasive, looking at the biologics of how to get the spine to fuse has really been evolving over the last few years.
With the Spiro technology now, you're combining the best part of titanium, the bony on growth, the biocompatibility, with the best parts of PEEK, which means the modulus elasticity that's similar to bone. That type of surface technology is sort of like the next holy grail in spine implants. How do we have something that bone's going to be very happy growing right up on, but we're not putting something that's so stiff that maybe we either cause subsidence or maybe even pseudoarthroses from having an implant that's just too hard.
It has nano effects, surface technologies. Depending on what kind of graft material, we can enhance fusion all through the implant. The implant becomes bioactive. So if you load the cell, it can either elongate or contract, but if it elongates, the cell signals to release growth factors. And one of the growth factors is bone morphogenic protein. And if it releases that and attracts more cells into the site, to then turn into bone. And these things actually become a bone or fusion machine. So instead of getting a problem where the fusion doesn't heal, we're enhancing the biology so it's going to heal in a predictable fashion.
These series are the first ones that are being designed uniquely for the oblique approach. When it's optimized for it, the positioning is easier. You can optimize the position, and you're not trying to jockey the instruments around trying to get it just in the exact position.
Surgeons will find the cage to actually be easier to insert. There's no rotation, there's no orthogonal movements needed in order to properly insert the cage. The cage itself, because of the vertebral body support and the contoured fit of the inner body cage, patients actually are not necessarily having as much pain postoperatively because the spine has been properly supported.
By going through this approach, the OLIF approach, it's really a muscle splitting approach. You simply divide the lateral abdominal wall musculature in line with their fibers. So you're not really cutting them or detaching them, you're simply just spreading them apart, which then translates into less pain postoperatively, quicker recovery, and by disrupting much less muscle, there's much less bleeding, so blood losses are typically much less. It's much better tolerated by the patient.
I would not push the envelope doing laterals when you had unfavorable plexus anatomy. So again, that would preclude me from accessing some of those patients from a lateral approach. So with the OLIF now, it opens all those up. The risk of any kind of neurologic injury with an OLIF approach is exceedingly small.
Basically, this whole project is all about trying to create a better mousetrap. It's taking the idea of OLIF and making it infinitesimally better.
We aren't necessarily reinventing the wheel. We're just evolving and perfecting it. We're coupling the least invasive approach with the fastest fusion to allow for quicker patient recovery, which is really what it's all about.
The stuff we're doing now is not your father's spine surgery, to paraphrase the old commercial.
No,
it's completely different.
There's nothing more rewarding than that patient that sits in the office with you, 6 or 8 weeks after surgery saying, I don't know why I waited so long. Yeah. This has been the best thing that's ever happened to me.
I think that it's not just the implant that's designed for that approach. It's not just the design of the implant with the superior biomechanical properties and superior biologic properties. I think it's a combination thereof. These things together will drive better outcomes for the patients and drive a more reproducible procedure that's perhaps easier to do for the surgeon.
If you get people back to work quickly, that's a huge deal. So from a medical, surgical, and economic standpoint, this has huge advantages. If you design an operation that only 3% of surgeons can do, that's a limited thing. But if you can design an operation that the average surgeon can do really well, then the population can benefit. So that's what we're trying to do.